I attended few other sessions today. One of them was updates in pulmonary critical care medicine. So it was Dr. Gulrukh Zaidi. She is the assistant professor of pulmonary medicine at Northwell Health System, New York. She gave an amazing presentation with a lot of updates in pulmonary medicine. The most interesting one I found was with COPD. So with COPD, previously, if they are really advanced COPD, and if you cannot control with your regular steroid inhalers or anticholinergic inhalers, so previously they used to do lobectomy, the surgeries previously, and because of the complications, because many of our patients are really obese with a lot of
poor surgical candidates.
Exactly, they are not ideal surgical candidates. So now they have two interesting new developments that they are doing, so which can help with COPD patients, surgical interventions, and one of them is called coils. So what they do is the interventional radiologist actually goes in, identifies the areas of the lung where they are hypoperfused. So they just put some coils and close that dead space. So you don't have enough dead space on whatever lung you have is all the viable lung. So they are basically essentially eliminating all the dead space by putting the coils around that area of the lung. So that's one interesting development.
Who are the candidates? Did they talk about like specific criteria?
No, so advanced COPD patients, if you see that the patients are recurrently being admitted to the hospital and they are on the best medical management with all the inhalers and they are compliant on these medications, but still they are having a lot of trouble. And also there are some criteria that she has mentioned that we have to see based on the pulmonary function testings. So the FEV1s and other criteria. So with those criteria and with this one, for recurrent patients who are not getting better on your regular management, send them to a pulmonologist and see if they are candidates for these new modalities of treatment, such as coils is the one that I was telling you. The second one was endobronchial valves. So they go in through the bronchoscopy, so they go into the part of the lung where the dead space is, and they just put a valve, so it basically just closes up that bronchus, that area of the bronchus, the dead space. So that also has dramatic improvements as per the physician, she was saying. People get better very quickly and their quality of life improved and they're able to do things which they were not doing in the past when they had this bad COPD. So that was interesting to know.
So here's my question. So is it still considered to be experimental treatment, or is it something payers like Medicare actually paying for?
I'm not
because
100% sure
because
on that.
that would be great
Yes,
consideration.
absolutely. So I'm not 100% sure on that if the insurance companies are paying for it, but it will be worthwhile at least to refer them to a pulmonologist to see if they are candidates, and definitely they can pursue with their own case managers or social workers regarding how to get it approved for them. So
Absolutely, because downstream, again, if you're able to alleviate that patient's symptoms, right, of chronic COPD, you hope that you're going to have less exacerbations, less downstream costs. So you hope that, you know, insurance companies are forward-thinking enough to approve these surgeries. Wow.
yeah, rather than admitting the patient 10 times a year and pumping all the steroids and sending the patients back on steroids and giving all the antibiotics. So rather than doing all of this, fix them one time.
Yeah, and from patient perspective, quality of life.
Exactly. Yeah. So the quality of life improves significantly. So that was interesting one. Yes, that was one interesting one.
So one thing I want to ask you, because we're both physician advisors, and as a physician advisor, I see Procalcitonin being ordered right and left, whether it's needed or not needed. So did they provide any clinical guidance for the best use of Procalcitonin?
Yes, so the guidelines do not really say when to use that, but based on the data we have, so Procalcitonin is best to use for prognostication, not for diagnosis though, for prognostication. So you can use or monitor the Procalcitonin levels and decide if the treatment is working and when you can stop the antibiotic therapy or when you can de-escalate the antibiotic therapy. So that's used for prognostication.
How often would you repeat it?
So normally you can check it at the time of admission,
Okay.
and within 1 to 2 days you can repeat it to see if the antibiotics, whatever you are giving, are working. If the numbers are going down, yes, absolutely, that is working. There is a special scenario where you can also use procalcitonin for kind of diagnosis. It's not 100% diagnosis, but to rule out certain things. If someone comes in with shortness of breath and you see infiltrates on a chest X-ray and the patient has COPD, so you believe that patient has COPD exacerbation, and now you are confused whether to give antibiotics or not because you see some infiltrates, and the infiltrates might be from a previous pneumonia 2 weeks ago or 3 weeks ago, so you're not 100% sure on that. So in those situations, you can order a procalcitonin test. It's kind of like D-dimer to rule out bacterial infections. Procalcitonin is a marker for bacterial infection.
Okay.
It doesn't change with viral infections. If someone comes with flu, procalcitonin has nothing to do with that. So if someone comes with a concern for if there is a concern for bacterial pneumonia, you can order, for example, the patient I said, you can order a procalcitonin, and if it is negative, you can safely say that the patient does not have infection, bacterial infection, so there is no need for antibiotics.
So would you use procalcitonin to decide whether patients with COPD without pneumonia needs antibiotics, or would you still rely on Goodall criteria? Somebody has productive sputum, it's green, it's yellow. So
that's always the standard. So you always should be looking at multiple things, not just one test. There is no one gold standard test for anything. So clinical criteria, if the patient is symptomatic, increased shortness of breath, increased sputum production, if there is a fever, if there is leukocytosis, all of this. But with all of these, this is just an additional tool. It doesn't take away your clinical judgment from clinical exams or anything. This just adds to your clinical diagnosis, whether you are comfortable, because when you see infiltrates and someone has maybe mild borderline fever like 99.5, it could be just from some inflammation going on, and you are concerned whether to give antibiotics or not, and we unnecessarily give antibiotics to a lot of patients. So for especially COPD patients, we just give, there is no need to give antibiotics to every COPD patient. So that's the idea, to use the procalcitonin there. So that helps a lot too.
So I actually appreciate that they provide, okay, we're not going to call them guidelines, but actually practical recommendation how to use this test, fairly expensive test, to actually guide and improve patient outcomes. Yeah.
And
what about perioperative care? Because more and more hospitals are involved in perioperative clearance and taking care of those patients in perioperative period. So any exciting developments we need to share? You need to share?
Dr. Barbara Slavsky. So she was the professor of medicine and orthopedic surgery, chief of section of perioperative medicine from Medical College of Wisconsin. And she gave a pretty good idea about perioperative medicine and the trends and what needs to be done. So the interesting ones I saw was functional capacity. Like, how do you assess functional capacity before clearing a patient? So previously we are all familiar with METS criteria, and now there is more evidence that rather than METS, there are a few other criteria which are more clinically useful than METS METS criteria. So one of them is the NT-proBNP, and the other one is DASI. So these criteria are used now for assessing the functional capacity in the patient.
As a sort of risk predictive tools.
Yes. So the DASI is a scale where the patient has to choose. It's a questionnaire kind of thing. So you give the questionnaire to the patient, and the patient checks everything, and they have a score depending on what they have checked. So based on that score, you decide the risk of that patient, their functional capacity. So that's a useful tool, and NT-proBNP is also another useful tool now, which are new that I've heard during this conference today.
And how that, what's recommendation for using that tool?
So both of them, so you can use one of those. So the DASI scale, DASI scale, or the NT-proBNP, and one of those, there is specifically nothing.
And is there any time frame they suggest to use this tool? Probably not when patient came in for surgery that day. You probably want to do it ahead of the time. So
And there is really no timeline like that. So just like you're assessing, like someone comes to the hospital being admitted and surgery wants a clearance from you. So obviously you'll have to do clearance at that point of time.
clearance is a scary word. Let's gonna call it risk certification.
Yes, absolutely, you're right. So yeah, we don't clear the patient for surgery. We just risk stratify those patients. So yes, so for risk stratification, yes, you can do it at any time. And one other interesting topic that came about was regarding how do you assess difficult intubations. So we all know about this Mallampati criteria, which have been there for a long time, which has a good positive predictive value. And there is a new study that came up, and the new clinical testing, you don't need any fancy equipment. All you need to do is just the upper lip bite testing. So basically
How exactly does it work?
Basically, you ask the patient to bite their upper lip to see, look, if they can do this.
Yeah.
So that adds that will be an easy intubation. If someone is not able to do that, then that will be a difficult intubation. So, and that has positive predictive value of 16. So yes, so that's really high compared to the Mallampati criteria, what we have already.
And it's easy, and it's bedside.
Yes. So there are some more studies on this that are coming up in the future. So maybe we'll have more data on that. So that's one other interesting thing that we came to know on that. And the other interesting thing was point of care ultrasounds. So they were telling about the relevance of point of care ultrasound for hospitalist physicians, and actually that makes sense. So the way she was saying,
ultrasound of
everything. Like today, she demonstrated an example of ultrasound of your lungs. So someone comes to the hospital with shortness of breath, say the blood pressure is low, and you are worried about, does the patient has pneumonia or CHF or cardiogenic shock versus septic shock. So you have so many, or does the patient have DVT? So with all of these, so she demonstrated that physicians can actually do bedside ultrasound, and you can look for the aeration in the lungs. You can see the Kerley B lines and other things, that those are normal aerated lungs, and even you can see the consolidation changes in the lung because you can see the hepatization of the lung. That's one other feature, cool feature, and you can see pleural effusions, obviously, and you can also check the ejection fraction of the heart. You don't need to know the numbers, but at least you'll know if
it's pumping or not pumping.
Exactly, if there is a cardiogenic shock or not. And also you can see if the patient is fluid overloaded or not by looking at that. And the other interesting one was you can check for DVTs as well. So you don't need, say someone comes on the weekend, and not every hospital has the technicians and everyone over the weekends, and maybe you might have to wait till Monday for 1 or 2 days, and you cannot hold the treatment. Or on the other side, since you're concerned about everything, you wanted to treat everything, which is harmful to the patient if the patient doesn't have all these problems. So I think Society of Hospital Medicine has started the certification course, and actually the hospitalists can get certified as certified in bedside ultrasounds, and it is jointly with the Society of Hospital Medicine. And I heard that starting next year, ACP will be joining with SHM as well in providing this opportunity.
Yeah, I think this is great. I mean, anytime when we use technology, portable bedside technology to enhance.
Yeah, we don't replace the conventional testing.
Exactly.
This is just for decision making quickly, rather than waiting 1 or 2 days. Especially if it's a night, you have to wait till morning to get these testings done, and within 5 to 10 minutes, you can just make a quick decision.
Especially if you can trust the technical skills. But again, if there is a certification from legitimate entity, right, then you don't have to worry about.
We had certification course, I think, yesterday here at the convention, they had ultrasound certification course as well. So you get certified, so you are trained.
But yeah, one is being certified, another actually be proficient, right?
Yes,
So we just need to make sure that it's actually some proficiency, because God forbid you don't want somebody who doesn't know exactly what they're looking for, regardless of their certification, and missing something or seeing something that doesn't exist. But absolutely, I mean, anytime when you...
We did that in residency, so we did bedside ultrasound. So you can even look for other things like SITs and other things.
I'm Dr. Marina Ferrin. Thank you for joining us, and see you next year.
Hey, I'm Dr. Kranti Seethamagari. Thank you for joining us. Hope to see you all in 2020.